Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Dr. Chris Carter, who is a critical care nurse from the UK. He's currently working in Zambia and just finished his PhD. Chris wrote one of the textbooks that we use on our Masters of Austere Critical Care program. Chris, welcome to the podcast.
Thank you so much.
So tell us a bit about yourself and what's keeping you busy.
Okay, so a little bit about myself. So I'm a critical care nurse, and I trained as a nurse in the UK, in London. And I've had quite a varied background. So I've worked in the National Health Service, and I've held various posts in the NHS. So I was staff nurse in critical care. Then I worked as a critical care outreach nurse and then a resuscitation officer. Then I decided to take the plunge and I joined the Army. And so I joined the QARNC, the Queen Alexandra Royal Army Nursing Corps, in 2008. And deployed to Afghanistan and also worked in different units in different countries whilst I was serving. And then in 2021, I decided to leave the army, and I basically now work for a university at Birmingham City University, and I'm an associate professor there, and I run a series of research, enterprise and innovation projects internationally, and I also run the UK critical care course.
Nice. So I'm curious, you started in the military in 2008. When did you go through battles?
Wow, I think I went through battles, I think in around 2010, I think. I think it was around 2010, I think I went through.
I was teaching on it at that point. Did you go through the one at Fort Blockhouse?
Yes, I think we've had this conversation before. I think our paths have met.
I think so.
I think you've actually taught me, and then I think we've actually been faculty together on that course, because I was also on the faculty for a number of years.
I think I was gone. So I left in 2012. So I'm not sure if I was still around when you came back from Afghan and joined the battles faculty.
Yes, because I think thinking back, I mean, it is so long ago, because I deployed to Afghanistan in 2009 and then came back in 2010. I did 6 months. I did 6 months operational deployment, and then I was posted to 16 Aerosol, to 16 Medical Regiment, and that's where I went and did my battles course. So it would have been around sort of that 2010 I went through, and then was nominated to become an instructor, and then taught. So I think our paths definitely have crossed during that time.
Nice. So you were 16 MedReg. Where was that located?
So at the time, that was based in Colchester, and I think it's still there, actually. Yeah, so it was in Colchester. So I was there for 3 years. Then I moved to the Defence School of Healthcare Education, so the Department of Healthcare Education, DHE, which was co-located at Birmingham City University. And that's really how my links with higher education really started in 2013.
Nice. And you're working in QE Hospital, was it?
So I was actually based at the university, so the academic department was separate from the QE, although we used to have our undergraduate students go across and clearly do placements at the QE, so had links there but never actually worked there.
So I'm curious, Chris, one day you woke up and you said, you know what, I'm going to go live and work in Zambia. So how did that work? And what was your motivation for going down, and why are you down there?
Okay, so I suppose this is where it gets a bit blurred, I suppose. So I was working at the Defence School, and it was 2014, and basically there was a call for critical care nurses nationally, and it was open to civilian, military, anyone. And the call was about an opportunity to deliver a critical care course in Zambia. So I was at a point in my career, I was thinking actually need an opportunity and wanted a bit of, do something different. So responded to this call. And there was a group of us that joined or, answered this call. And basically we found out that there wasn't any funding, there was no real program, there was nothing really in place. What was in place was was essentially there was a team of UK anaesthetists that was delivering a master's in anaesthesia program in Zambia. And they were using a similar model to what we used to use in the UK, where an anaesthetist also had to cover the intensive care unit. And one of the consultants that was working on this program was an intensive care consultant and anaesthetist, and basically recognised that in order for their program to reach its full potential, they needed to start investing in the nursing workforce, because they were finding that they were leaving medical plans. They were trying to sort of, move the critical care agenda forward, but they were finding that the nurses weren't necessarily able to do that because they didn't have access to higher education and training. And that was really the call. And then so we had lots of discussions, and I ended up leading the project. And I was doing that alongside my military role. And I had the opportunity to visit in May 2015. And then that was our first needs assessment. And then when I came back, I spoke to one of the associate deans at the university. And basically that's where the collaboration started, and BCU sort of became sort of the lead partner in sort of the running and organisation of that program. And so it's been running for over a decade now, which has gone really fast when I look back at all the stuff that we've done, but it's a long time.
And how often are you down there?
So in the early days, I was in the military, so I was using my leave to basically support the project. And we had a team I worked very closely with a professor of nursing, Professor Joy Notter at BCU. And so a lot of our work was in short stints, and to do the in-country piece, it was done during annual leave. So it was quite difficult in those early years. And then as I left the military and transitioned into BCU, then basically my time actually, because I was able to use more of my academic time to support the projects and the applications. And then from that's where it's really grown from sort of that 2020. I mean, one of the things that we had during that period, as I'm sure we've all had to live through, was COVID. And so it was an interesting time, because prior to 2020, we used to have a lot of trouble trying to get research grants, innovation grants, capacity strengthening grants, because the theme was, why do you invest in critical care in a low resource setting? It's a waste of money. And we used to get a lot of backlash, and we used to get a lot of backlash from NGOs, but we also used to get it from anaesthetists saying that, surgeons, the only way to enhance, the agenda is to invest in safe surgery. And while I agree with all of that, our narrative has always been we need to strengthen the entire pathway, because you can have the best surgeons and the best anaesthetists, but if the patient isn't optimised prior to surgery, or the post-operative care is not on point, then actually the outcome is poor. So we were always struggling sort of in those early days. And, we had some very good funders that actually understood what we were trying to do. And then when COVID sort of happened, suddenly there was this recognition that we needed critical care, and there was a critical shortage within the region. And as we were one of the few projects, partners, organisations actually working in that space, our work really took off. And so we worked with partners to really capacity strengthen critical care further. And we were one of the few universities and organisations that actually stayed in country and actually had a footprint in both education and practice, because we felt that competence couldn't be taught through YouTube or through Teams or Zoom. So we actually had a team in country, and I actually had the opportunity of leading that team during that time. And that's really what's opened up a lot of our opportunities that we're running now.
So the critical care nursing also includes surgical nurse. So you were asked down by the anesthetist and surgeons to train up the surgical nurse for theater, but that falls under critical care nursing as well?
Oh, sorry. No. So what happened was, theatre nursing was running, but as I was saying, the way that the model that they use in Zambia is the anaesthetist, the physician anaesthetist, also covers the intensive care unit. So they have a dual role. So they literally will have an on-call and for intensive care, but they'll also have an on-call for theatres. So the programme that the UK anaesthetists were running actually had a critical care component to it, and that's separate to anaesthesia and surgery. But it comes under that umbrella of anaesthesia from the physician's perspective in Zambia.
Nice. And there is a master's program for critical care nursing. Does that mean there's a master's program for your surgical nurse?
So what we did was, the approach that we used was we developed with local partners their local programs. So when we started in Zambia, there was actually a critical care program running. It was an advanced diploma, a 1-year program, but it had a critical shortage of faculty, and the curriculum was quite UK centric or high income centric, and it wasn't fit for purpose. So we worked with stakeholders in the country to review, refresh and update that advanced diploma program. Then we worked with universities and the regulators and the Ministry of Health to develop a bachelor's program. And then we worked with the university to help operationalise a master's program in critical care nursing. So we've done the full suite of courses in Zambia, and we've done the same for emergency and trauma nursing, and we're doing the same for cardiovascular nursing, which is a new speciality that doesn't exist in Zambia at the moment. And then what we've done alongside that is we've run our own UK master's program to pump prime faculty and leaders in practice. So we've done a one-off program where we take senior educators who are critical care nurses, or cardiac nurse, or work in the cardiac space. And then what we're doing is we're basically doing a train the trainer whilst we're helping to develop their local programs. So that's our sustainability plan.
So BCU, Birmingham City University, has sent you down to create these programs. What is the connection with BCU and Zambia?
Well, the connection came from really my links that I had. And as you know, universities have international links, international research projects running. So the university saw it as an opportunity to expand their international portfolio, and also to be involved and really to lead this work in that field. And we have a number of international partners as a university. So Zambia is just one of them. So we have a partnership in Malawi, one in Vietnam, one in Romania, and they're just the ones that I'm involved in through the Centre for International Health Partnerships. But the university has a whole range of international partners. So it was really an opportunity for them to really sort of see how they could, increase their footprint and the opportunities for both staff and students in the region.
Chris, you created a book called Critical Care Nursing in Resource Limited Environments, and we've picked it up for our Masters of Austere Critical Care. Is that from your motivation for that? Does that come from your time in Zambia?
I think it's a bit of a mix, actually. So I think it came from my time in the military, because I saw, you could see that there was lots of opportunities, for us to sort of think, how we do things differently. And so there was that element of, reflecting on, my own experience of working in different healthcare settings, and sort of thinking you have to think differently. So I think there was an element of sort of definitely from my military experience. And then it was linked to my experiences, particularly in Zambia and in other countries, thinking actually we need to think differently how we prepare people to work overseas, because there's lots of differences, but there's also lots of different ways of doing things, lots of innovation, lots of different ways of doing things, but also the importance of preparing and, and thinking through what can get you prepared, what you need to prepare when you're working overseas.
So you've written that book a few years ago. Do you have people contacting you about what you've done there? And is there a possible update in the making?
Absolutely. I mean, I would love to do an update for this book, and I would love to have more authors join me to review this. And I think back in those early days when I wrote that book, it was very hard to find people that of the similar mindset, of the similar, that were working in that space. Whereas I think if we fast forward sort of nearly 10 years, I think there's a lot more people working in that space. There's a lot more a lot more opportunities. And I think also it would be great to have authors from actually the region contribute to the chapters, because, the knowledge in that region is really growing exponentially. And I've certainly seen that in the countries I've been involved in, discussions with other universities and partners that are working within the region. So it's not really the same landscape that I started with. And so I think there's, of course, lots of opportunities. But like I said, I'd like to see a lot more collaborators and contributors to the next edition if I get the opportunity to do that.
I'm thinking of the time that I spend at KCMC in Tanzania. There's nurses there that would be interested in that. And Ghana as well, in Kumasi, halfway up Ghana, in the middle of Ghana, there are critical care nurses there that are on our faculty that run a very, very good program. So it would be interesting to have a second edition. What would you want to change, Chris? What would you want to add to this new textbook on critical care nursing in resource limited environments?
Wow. So I think, like I said, I think at the start, the critical care wasn't really discussed. It was, I often describe it as being hidden in plain sight. So in many of the countries, there was a critical care unit. There was a functioning critical care unit. It's different to what maybe we see in a high income country. But then we see wide variations between what we see in Europe to what we see in, let's say, the US. So I think, there's lots of, it's become much more explicit. I think COVID's done that. Things through your program, through our program, through our partners' programs. We've seen critical care, the agenda has changed. And so a lot more countries now understand it and services are developing. So I think it needs a good refresh, actually. And I think it would be great to sort of have, like I say, multi stakeholder contributions to it. And I think I'd like it, if I had, this is the world according to me, I think I'd like it to maybe reflect sometimes more the curriculums. So, let's see if we can do like a book that actually talks to all the different curriculums, because there is the World Federation standards for critical care education, but actually align it maybe towards more of the education programs that are out there. Whereas, like I say, 10 years ago when the idea came about, there wasn't really much education in the region. It was very much short training courses. There wasn't much faculty there. So I think there's a huge opportunity to really update it. Evidence has changed. And I think I saw that when I did my PhD, looking at the literature that was published pre-COVID to what was published from sort of 2022 onwards. It's grown exponentially, the amount of research that's coming out of Africa relating to critical care. So that reliance on high income country evidence is still there, but it's actually reducing. So I think there's an opportunity to really refresh it on lots of levels.
Would you consider adding prolonged casualty care to your second edition?
I think so. And I think, that's a really good point, actually. I think that would be something really important to consider. And I think I think we talk about prolonged casualty care maybe in different perspectives. My experiences, particularly in Central Southern Africa, has been in quite stable environments. So we talk about prolonged casualty care, is that moving someone from a rural hospital that requires critical care to a critical care facility, or it can be, the more austere, a trauma setting. It could also be, someone on a ward and there's, because we don't have enough critical care beds, so we have to optimize them for a prolonged period of time before moving them until a bed becomes available. So I think that prolonged field care can sort of mean lots of different things in different settings, but actually a lot of the principles are actually transferable that we all need to consider. It's just the environment that we work in. So I think absolutely that would be a great addition, and I'm hoping you would be interested in contributing to that chapter if we get the opportunity.
We can definitely have a chat about that. And when you and I were teaching in Battles 15 years ago, prolonged field care was part of that. And even before the word prolonged field care came in, it was part of the curriculum. And the military has been pushing for PFC, for prolonged casualty care. And when I go to Africa or other LMIC countries, and I see what they're doing, they're doing prolonged casualty care. They just call it care. And every time I go, I learn something. I look at how they're dealing with casualties, and they are doing what we've been trying to redesign since 2014, prolonged field care. And this is what they do. And I would be interested in seeing your second edition of the critical care nursing and resource limited environments to maybe address, to bring up those of us who are in operational environments, or those of us who are dealing with prolonged casualties, to use your book, as we are in our master's degree now, but to look at the current evidence from the past 8 years and probably implement some of that prolonged casualty care that other people just call care. But for us, it is a challenge to do this in low resource.
Yeah, absolutely. And I think, when I reflect on some of the experiences I've had, particularly working in the non-military setting, and clearly we've had military personnel come and work with us over the years in different settings and things. And one of the things I think we sometimes see in that, which we don't sometimes recognize, is the flexibility. And that when you have to have that, you're in a situation, you have to be flexible and you have to think outside the box. And I think that's something I see every day when I work with clinicians, not just nurses, doctors, clinical officers, physios, in practice, is that actually everyone's, that flexibility. There is, and that's what I think prolonged field care is about what do you have in that at that moment in the here and now, and how do you address it, but how do you apply the principles with the resources that you've got. So I think there's huge opportunities for learning from both the military but also from our colleagues in low resource settings.
Plus, there are a ton of resources now, published research on PubMed, focusing on the prolonged field care or prolonged casualty care concepts.
Absolutely. And I think there's a huge opportunity to bring all that together into really a practical guide. But I do think, like a lot of resources and things, that's where things like education and training really come into their own, because it's how you can sometimes operationalize them and actually give people the ideas and the toolkits to do it, because I think that's really important. So one of the work streams, one of our projects we have running at the moment, is around rehabilitation following critical illness. Because what I found, particularly in Zambia at the start, was everyone was focusing on what I call the drip, drama and dilemma, all about intubation, resuscitation. And they are really important. They're really important phases in a patient's care, because if we don't get them right, then the patient doesn't survive. But actually the question that we've been asking for a number of years, and sort of stems from COVID, is really what happens when you have a patient on the ICU for 24, 48, 72 hours, some of our head injury patients that are there for weeks. What about their rehabilitation, and what happens to them once they get discharged from the ICU? What's their ongoing care? So one of the things we're doing at the moment is putting together a toolkit which is based on research about rehabilitation following critical illness, to try and bring some of that theory, some of those concepts, and some of them do overlap to prolonged field care, because you're reversing the pathway, as it were, and actually making it much more practical for healthcare professionals when there's very few people around to actually deliver that important care.
What aid memoirs do you see being used in Zambia? If we created a field guide of austere critical care, would that be something useful for the hospital you're currently are working in?
I think so. I think there's huge opportunity, and I think there's huge opportunity for, particularly, I think an aid memoir for me is also like a protocol or a guideline. So also it's that, that handrail to use in practice. So I think it's giving people those tools to actually think about what can you do when you don't necessarily have, you may be a physician anaesthetist who can be with you because there's so few of them. I mean, we know from the research that I've done, and from other studies that are out there, not just from Zambia, but a lot of nurses work in isolation, particularly outside of the capital. So they may be the only critical care practitioner for the hospital. They're often working in isolation with very limited support. And so I think any aid memoirs, any guidelines, anything that really can help people to provide that professional support in their decision making is really important. And likewise for the doctors, because often the doctors, there's even less of them and they're working in even more isolation. Everyone looks at them and they're expected to know everything. I think I see it on many levels, the opportunities.
Indeed. Chris, you've mentioned innovations a couple of times in Zambia in your work there. And I'm fascinated about improvised medicine. Are you seeing any improvised innovations in your experience outside of the UK that would be something useful for the critical care nurse?
We see a lot of innovation on lots of different levels. So, for example, we've got a low-cost, highly sustainable enteral nutrition project for critically ill patients, which is where we use um, locally sourced provisions, as it were, to actually provide a specialist feed for patients in ICU, and that's been running for 3 years now. And we've seen that the number of patients that drop weight in ICU reduce, and we've also seen the incidence of pressure ulcers reduce during that time. And we've had a team of dietitians and intensivists and nurses in the UK that have supported that project over the years. So you see huge amounts of improvised, different ways of doing things. And I think from a UK perspective, sometimes when you're trying to explain this, you sometimes get, the traditional, like, no, we can't do it that way. But actually, when you start thinking about it, particularly in the UK, we have children with long-term medical conditions that are in the community, and families blend their own foods and they don't use commercial feeds. So for us, a lot of the evidence may not be coming necessarily from critical care where we use the commercial feeds, but actually the concept is accepted here. And actually what we're doing is we're using the expertise maybe in a different part of the healthcare system to actually think, how can we adapt that and utilize it and have the evidence in order to make sure that it's safe in that setting. And likewise, when you put the two teams together and you start having those discussions, it's really fascinating to see people thinking, why do we do it this way in the UK? Why do we do it this way in Australia? And actually thinking about how we can all learn and actually think differently about sort of approaches. And that's just one example in relation to nutrition.
Have you published that?
So we've published some of it. And so we've done a critical review of the literature and we've published the findings. Every year we've been publishing or presenting the findings at national conferences. So we've been presenting those within the region. So that's been in Zambia mainly, but also we've been presenting at the British Association of Critical Care Nurses. And I think what we're now starting to see is a lot more integration. And I think, COVID, one of the good things from COVID is, Teams, WhatsApp, all of these platforms have really encouraged much more opportunities to be linked and connected and to discuss things. Whereas sort of pre-COVID, trying to set up a call, we all used, Skype? Everyone was all like, oh, I can't use this. And it was all sort of like a barrier So I think, we've certainly seen a lot more opportunities for that sharing of knowledge and discussions, and also getting our partners in Zambia to actually present at these conferences. So it's not, like I say, the world according to me, even though it's not. I have a whole team and a team in Zambia, Malawi, Vietnam that help, but often I'm the face of it all. And actually it's really, the internet has given us that opportunity to really get them involved and actually for them to talk about their experiences and be part of it, because they are the future, and they are the sustainability plan.
So, Chris, you've recently completed your PhD. Congratulations.
Thank you.
You did that through BCU. So can you tell us what your doctoral thesis was?
Okay, so the thesis was around the development and evaluation of a conceptual framework and model for critical care nursing in Zambia. And what it really looked at basically defining what critical care nursing is in the country. Because as I said before, there's different we'd use the term critical care or intensive therapy unit, but actually there's a lot of interchangeability in what different countries provide in terms of critical care. So it was around defining the role, the scope of the nurse, of the critical care nurse, and then building a career framework and structure for the critical care nurses, recognising the different levels. So going from a student nurse, so from pre-service all the way through to PhD. Because one of the things I always used to say was, we're bringing in all these education programs and, countries want to enhance them and introduce them. But I say to them, what's the difference between a diploma, a bachelor's and a master's nurse, or and the same for a doctor, same for any professional group. So it was really around sort of understanding that hidden identity, the hidden part, the complexity in the different levels, and what what actually happens at each level. And that's why you're developing a workforce over time. And that was really my thesis. So it was a big piece of work.
And are you seeing a difference between a bachelor's degree nurse and a diploma nurse?
Absolutely. Absolutely. It's taken time, but we are seeing the difference between a diploma, a bachelor's and a master's nurse in Zambia, which is really positive. So we're starting to now see the critical care nurses that are completing bachelor's are now starting to take their seat at the strategic table. So we're now starting to see them being much more involved in discussions around critical care development, around sort of nursing development. And also we're starting to see a lot more leadership in practice. So we're starting to see that, not just the clinical care improve, but we're also starting to see sort of the leadership and the management and actually starting to see that traction as a professional group to get the recognition. And as I've talked about, some of the projects around rehabilitation, nutrition, this is all sort of stemmed from master's students that actually have started to recognise that actually we need to move the care agenda forward. Of course, we need to do the emergency work, but also we need to start thinking about what's happening to our patients. So we've had lots of different, we've seen the care sort of evolve in different ways. We've seen rehabilitation, follow-up clinics, use of patient diaries, the nutrition, rehab projects. These are all just examples of how care is evolving and moving forward on a higher level, as opposed to where previously it was very task-centric. It was very much focused on sort of the resuscitation and stability of an individual.
So it's definitely needed to have that input. Chris, my final question for you is this. What advice do you have for the new nurse, the new doctor, the new paramedic who is just starting out in their career in austere medicine?
It's a good question. I would say, embrace every opportunity. I think there's lots of opportunities out there. And I think when the opportunity arises, take it. And I would say, I've had a very varied career. I've been very fortunate. But I also think when an opportunity has arisen, take it, because it's going to take you somewhere. And I think there's lots and lots of opportunities out there. And I would take every opportunity that you get. I would say it's a difficult career to work in because there's not necessarily a career structure for us. It's not necessarily a proven track record, someone to follow. It's very, you have to find your own path. But I do think, there's huge opportunities, and I would say take each opportunity as they arise because it's going to take you somewhere.
That's good advice. Well, Chris, thank you for joining our podcast. And personally, I want to thank you for creating your textbook, your critical care nursing in resource limited environments. And it was an obvious choice for our master's program to include that. And I look forward to seeing what you can do in academia.
Thank you so much. Thank you. Thank you for inviting me to be part of the podcast. And, and I've really enjoyed working with you over the years. So thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website